Okay, thank you so much, Adam, and welcome everybody. Thanks for being with us today. So as Adam mentioned, our topic is assessing the reliability and validity of the violence assessment tool. And I want to give credit to CROSH and the public service agency that provided funding for this project. So workplace violence is towards healthcare providers and nurses has been increasing. And it was identified that more female nurses were getting incidents of violence. Increased rates are 8% higher in northern eastern Ontario. And we've got at least 56% of lost time due to injuries in Ontario from violence. There are consequences for the person, such as anxiety, anger, depression, and guilt, plus negative health outcomes to their well-being and quality of life. There are some common issues, factors that can contribute to the existence of the violence, such as underreporting of violent incidences, lack of policy in place for people to report, lack of support for people who have had an experience of a violent incident, and perception that violence is expected as part of the job. Some patient factors contribute as well. Sometimes patients are not happy with their treatment outcomes, or they have mental health issues or alcohol and drug abuse, or a history of stress and aggression and a feeling of powerlessness. So one of the main suggestions, other than education and zero tolerance, was the need for a violence assessment tool that is predictive of the violence. So there are different tools to assess risk of violence, but none of them have actually gone through statistical testing for reliability and validity. So then the Public Services Health and Safety Association developed the VAT, and this one is for acute care settings, but they're also developing for other settings. And this was recommended and supported by the Ministry of Labor, Training and Skills, and the Ministry of Health and Long-Term Care to be used in every hospital in Ontario. Now it's mandated, however, that's not happening yet. So some hospitals are in the process of developing their policies. So what we came up with a mixed method pilot research study, and we have one acute care hospital in northeastern Ontario that agreed to be part of our study. And our questions are, what is the predictive validity and inter-rater reliability of the VAT instrument? And are there any missing factors, components, or behaviors in the tool that need to be included, modified, changed, or to assess the risk factors that predict violence? So for phase one, that's the quantitative phase, that's actually still in process now. There was a lot of barriers to getting ethical approval because our quantitative data involves patient charts. So that's is very highly scrutinized. So there was a lot of process, and then with COVID delays to get data collection started. But we did get it going, and we have 3 different units where we're collecting retrospective patient charts from. It's a medical unit, the emergency department, and 1 adult inpatient medical unit. We need approximately 300 charts per each unit to review. Now, what we also did was take a look at incident reports of violence. So they had, this one hospital has a separate reporting system so that we were able to go there for each of those units and document what type of violent incidents or what type of incident it was. We were able to track that patient's SA number, hospital number to the chart. So we could also review the chart to see if there was a VAT assessment completed. So that's part of the process, which is still ongoing. And then what we're going to be doing is logistic regression statistical analysis, and inter-rater reliability is being done through. Sorry, this is still, oh, is she frozen? So the preliminary findings for phase one so far is we had 51 incidents from the medical unit, 128 from the emergency department, 264 from the inpatient adult mental health unit. So a total of 443. So we still need 457 charts that are being pulled randomly to assess for the chart. Okay. And I think phase 2 now, that's for Fego, if she can take over. And I think she might be having some issues here.
I'm ready, but permit me to please turn off my video because my internet is a bit unstable. Can you hear me? I can go on.
Yeah, okay. Do you want me to change you want me to change the slides, Fego?
Yeah, you can do that. Thank you. Yeah,
okay,
I'll let you know when to proceed. Yeah, thanks.
Yep, go ahead.
So for phase 2, it's being guided by interpretive description methodology by Sally Turn. So qualitative data collection, this began in July 2021, lasted up to October. Sampling was through propositive and snowball sampling methods because nurses were quite busy and we needed like time and nurses to recruit, like help us recruit their fellow participants and who will be willing to participate. So participants actually were one of 3 focus group sessions, which lasted about an hour to an hour and a half. So 4 short educational videos was shown to these participants, where actors displayed violent behaviors and they were asked to score the violence assessment based on what they observed. Similarities and differences in scores were also discussed and alongside the demographic questionnaire. Next slide, Judith, thank you. So the focus group data analysis was transcribed using the Cookart and Radiker 2019 transcription of audio methods. The data analysis was guided by Brown and Clark 6 steps of data analysis. So to do this, I manually transcribed the 3 transcripts. This would give me time to, sync myself in the data and familiarize myself more with it. And it also gave me opportunity to go over the data more than 3 times. And so following Brown and Clark 6 steps, I was able to identify codes and patterns that kind of like came together and were able to develop teams and sub-teams, which is actually still ongoing currently. Thank you, Judith. Slide 9, next slide. Okay. So out of 31 nurses who actually indicated interest to participate in this study, 14 participated in one of the 3 focus groups. Majority of these participants were emergency department nurses, majority of them were females. The years of working experience actually as working as RNs, registered nurses, was between 1 to over 25 years. And years working at a particular hospital was between 1 to less than 25 years. And years working in the units that they participated in for the study. So the emergency department, the mental health unit, and medical unit was actually between 1 to 25 years. So all the nurses actually had some form of experience of physical and psychological violence. Occupational health and safety has defined violence as 4 types. So we have the first type, the external perpetrator. So in this case, the patient relatives, family, friends. The type 2, the client, which is the patient. Then type 3, employment related to among co-workers. And type 4, domestic violence. Violence has also been defined as physical and psychological by the Canadian Nursing Association. So the nurses actually, all of them experienced type 2 physical and psychological violence. And for the nurses who experience physical violence, a few of them reported that they experienced type 1 and type 2. And for those who experienced psychological violence, majority of the participants actually experienced both type 1 and type 2. A few of them reported experiencing type 1, and a few a combination of type 2 and 3, type 2 and 4, type 1, 2, 3. So overall, the type of violence experienced for both physical and psychological was mainly type 2 for all participants. So like I said earlier on, the teams is still being being developed. It's still being developed. So far we've been able to arrive at 4 teams. So nurses' perceptions of the VAT, nurses' perception of violence, then overall awareness, recommendation and changes, and these have sub-themes under them. I'm going to give the next slides like a few excerpts supporting the nurses' perception of violence and what we have so far. Next slide, please. So for the nurses' perception of violence, so one of the sub-themes was abnormal being normalized. So they've actually normalized violence. So an example of the excerpt is, so from this ED nurse, it's becoming normalized for sure, but I also think nobody wants to take any sort of responsibility over trying to manage the violence. That is just kind of become the nurse's responsibility. There's no interdisciplinary responsibility. Then another ED nurse says, yes, the more the behavior is normalized, such as the screaming, the more that it continues, because we've seen it on a shift. If someone starts screaming in triage, they all start screaming. It just seems to make it okay. Next slide. Then for perception of violence management and your past experiences of violence, another ED nurse states, so like I just came back to emerge a few weeks ago from the ICU, and on my second shift, I was verbally assaulted and nearly attacked, and probably would have been attacked if it wasn't for the fact that the police stepped in right then. And that was my second shift back. So on a scale from being spit on to being punched like that, I find throwing being more actively physical with your limbs to be more threatening. That's higher. I have a lower threshold for that as opposed to like spitting, because the consequences of getting spit on, at least in my mind, are not as bad as being hit. So the nurses, next slide, Judith, please. So the nurses actually feel like most of the responsibility for managing patients is actually falls on them. So their job role has gone past caring for the patients and now actually managing them for violence, because they don't really have the kind of support that they require. For the team on recommendation and changes, so this nurse says, I've had patients that have experienced care for that have been on the floor for a few days with a history of violence. And we're still unaware that sometimes it's just a loss in translation. So somehow the nurses are unaware of the patient status. This suggests changes, most likely, maybe in hospital policies and processes, to be able to make the nurse is actually more aware of the patient status on presentation. So the nurse says, I think that one of the problems with the violence assessment, regardless of which one it is that we don't really know their status until after they're registered and we go looking for it. So someone who might present normally could be a real-time bomb and we're not aware of it until after the fact. I don't know what the answer to that is. So here we see that even though they use a tool, many times they cannot even find the tool until the real fact has happened. The violence has, an event has taken place. They now start going around looking for the tool. So it still boils down to hospital processes that need to be changed to make this tool available for the nurses. Next slide, please. So next steps of phase one. The data collection is still going on. The files will be transferred for statistical analysis. For phase two, the data analysis is still ongoing. The strengths of this research, the first one is that it's a mixed method, and we also conducted this in the Northeastern Ontario hospital setting. One of the limitations is that it's just one hospital. Then we also had the possibility of selection and sampling bias and response bias too from the participants. And thank you.
Excellent. Well, thank you for an awesome presentation, everybody. I have one question here. Dr. Horrigan, are there differences in experience between rural/remote and urban, or are the experiences the same to your knowledge, particularly during the pandemic?
So they're talking about experiences of violence. We haven't really delineated that because we're dealing with one urban hospital. So we haven't done a study among rural or remote areas. So I really don't know about that. Unless Fego in the literature, is there differences from other studies that show that rural, remote people are more vulnerable?
Okay, excellent. And nursing is primarily a female profession. Has there been any comparison to statistics with regards to all gender-based violence provincially, nationally, and internationally? Is this part of a larger problem with regards to male violence against women, and how it tends to be minimized in a particular society?
Very good question. That's not part of our study, but that sounds like it could be an excellent study to do in the future for sure. We haven't looked into that, so, but that would be part that we need to look at for sure.
Okay, excellent. I think this also kind of touches this on the same question, but were nurses more likely to experience workplace violence based on perceived gender?
It seems like on the first slide that we were talking about, it seemed that more females were affected than males based on that, but that can also be because of the heavy percentage of female nurses.
Okay, excellent. And would you say that VAT tool will be used more to prevent violence, or will it help to teach how to respond to violence?
It's more of a risk assessment tool, but there is like the Public Services Health and Safety Association have kits available to teach and train, but also to how to implement different programs to help prevent the risk of violence. So this is just one little piece of the entire approach to implement to reduce the risk of violence. So our little piece is just looking at the validity and predictive properties of this risk assessment tool. Yeah. And also for changes, like the focus groups are from nurses who are living the experiences, and their feedback will help also make changes to that tool. But right, and we didn't show a picture of the tool, but it's basically the first part, section A, is all of the type of behaviors, like is the person confused? Are they swearing at you? Are they lifting their arms? Anything like that, and there's a score. And then based on the score, section B talks about potential actions that you can take to help minimize the risk of violence. And then part C, each hospital can customize their responses based on their policies. Anything to add to that, Fego? Nope. Okay.
No, actually, you answered the question well.
Okay, thanks. Yeah, it's exciting to be part of this. It's sad that it's still continuing. What we've noticed is that hospitals are maybe slow on the uptake of using it. So we have to be able to determine that as well. The user-friendly ability to access that, to assess it. And there still needs to be lots of training and education on ensuring that nurses or whoever the healthcare professional fill in this form. It's important.
Excellent. And then another question for you is, did staff express concerns about how and where this information would be completed and how often it would be reassessed?
Sorry, are they talking about the focus group data?
I am unsure.
Can you repeat the question?
Yeah. Did the staff express concerns about how and where this information would be completed, and how often would it be reassessed?
Okay, well, I'm thinking that's referring to the VAT instrument. So some hospitals already have an electronic VAT instrument loaded into their computer system, but also they were mentioning that there's some difficulty in locating that. The assessment does have, the tool itself has recommendations on how to fill in the form, how often. So it depends on what unit and the behaviors. It could be done once every shift, could be done once every 8 hours, once a day. It depends on the patient. I hope I'm answering the question.
Okay. I think you did. If not, we can discuss it in the brainstorm.
I'm gonna add to that.
Oh, okay, go ahead.
Okay. Yeah, so what I wanted to say was, so the nurses actually said that when doing the session, so they usually don't bring up the form to score patients except they like notice symptoms or signs of violence. So it's not something we usually do on a regular basis for every patient that presents, except they are presenting with signs of violence.